let's move on to the second phase. How do we treat these children? We need to look at guidelines, pathways, the best way to treat these children. As you all know, these children undergo multiple treatments from multiple specialists. We need to be very careful and follow a guided approach in choosing any treatment we provide for these children. I said when I started that we grow up with these children, so we treat them from 0 to 18 years of age. So as you can understand, the number of times they visit us, the number of treatment phases they have is quite high. So the minimum you do is possibly the best treatment you can give for these children. So picking up and doing the treatment in a much more guided and reducing the burden is the key for treatment for these children. Sadly, 19% of the children in India, from the data from 2010, do not have access to treatment. And I'm sure with the NGOs that have done a tremendous job in India, like the Smile Train and other non-governmental organizations, funding Cleft Care has made a huge impact for access to treatment. There is a high burden with multiple treatments for these children from birth to 18 years of age. We as orthodontists are one of the first ones to treat these children. Of course, it's the nutritionist who guides them on how to feed the baby as soon as they're born. But soon after birth, we pick them up and we start some treatment, which I'm going to go through in a few minutes' time. They have a very high burden of care, right? They see cardiologists, they see doctors, they see surgeons, they see speech pathologists, they see feeding nurse, they see psychologist, and multiple treatments from multiple specialists all adds up into their lives. The caregivers for these children, parents or whoever is caring for them, have a lot of burden on them to bring them for every treatment from every specialist. So what we need to do is make sure that the treatment is absolutely essential before we embark on treating them. So this is a guide that we have for care pathway for children with cleft in Scotland, which is nearly the same across the UK, and it is the same across the globe. So we start off with the prenatal diagnosis, the box shown without any colors on, which includes the counseling and taking care of the parent and the caregiver. And then the baby is born. Immediately after the baby is born, they are seen in the multidisciplinary clinic. A multidisciplinary clinic will have the plastic surgeon or the maxvac surgeon or ENT, some kind of surgeon who are experienced in treating these babies. Have an orthodontist, have a feeding nurse, you have a cleft nurse, you have a pediatrician, pediatric dentist, ENT/audiology, and it can have many other people on board like nurses and trainees. And multidisciplinary clinic is a bit intimidating, or I shouldn't say a bit, it's quite intimidating for the parents and caregivers, for everyone in one place surrounding the baby. So hopefully we wouldn't do too much of intimidation for them and try to split it up. But that is essential to devising a plan for the next 20 years for that baby. So we sit together, formulate a plan for the rest of the 18 years of the baby's life, and we explain to the parent, the caregiver, on what treatment has to be done at what stage, a full pathway, which is what is shown in this flow chart on the screen. And then we also give them written leaflets to make sure that they understand and take on as much as they can. And then they go back and go through this. Any questions, they come back for a different time to answer the questions with individual specialists. So at the multidisciplinary clinic, we have a plan. Then at 6 months, they do have the orthodontist to do the pre-surgical orthodontics, which we'll talk about in a minute. And the routine protocol for us in our center is 6 months of cleft lip operation. So they close the lip first, and then they do the palate at 1 year of age. These are carefully done so that the surgery happens at the latest time point and it doesn't affect the growth of the child. And at the same time, it doesn't harm the normal milestones that the baby is going to get through their infanthood. After the 1 year of palate surgery. It's then up to the speech pathologist guys to make sure that they do the speech assessments and treatments, what they need. Us as orthodontists and dentists, we monitor the babies. As dentists, they monitor the babies or the children's the oral health. They continue with it. 5 years, we take an audit. We do simple records of their facial appearance, their nasolabial appearance, their gums, the speech, etc. And at 7 years, they come back to the multidisciplinary clinic for a further assessment on what needs to be done from there. We will then follow them up, any orthodontics, any surgery that is required, like alveolar bone graft and so on, until they are to 16, 15 years of age. We then do another multidisciplinary clinic around 15 years of age to make sure that they need any surgery for jaw movements and so on. So they do come and visit us quite often. We do give them a lot of information every time they visit us, what treatment has to be done and so on. And the multidisciplinary clinic is a starting point for every specialist. From there, they take them individually and start doing their treatment. The first one, I'm going to look at the different phases of orthodontic treatment in this lecture. So the first treatment that we provide for these babies is called nasoalveolar molding. So it's a molding of the alveolar segment and the molding of the nose to make it easy for the surgeons. This treatment is started as soon as 5 days after birth. So the baby is born, the feeding nurse gives them advice, cleft nurse gives them advice, some counseling happens, and then they come straight to us. We then take it over and start with their treatment. The idea of this type of treatment is, just imagine there is a wide cleft, right? There's a wide cleft. A wide cleft, I'm calling about 1.5 centimeters, 15 millimeter wide cleft, like how you saw on the picture before, if I can get through to that picture. So this, you could call it as a moderate cleft. So if that gap is really, really wide, right, really wide, what happens is the surgeon tries to operate. The surgeon tries to bring those two segments together and suture them. I'm just talking in layperson's terms. Don't take it literally. So if the surgeons bring the two segments together, what then happens is after surgery, there is a big stretch. There is a big stretch. Things want to go back to where they were before the time of birth. So that puts a lot of stress on the tissues. When it tries to go back, the scar gets wider. So any surgery that they do, there is going to be a scar. Any surgery, when there is a closure, you get a line scar. The best surgeons have the least scar, that is a really small line. Sometimes it becomes very difficult for the scar to be controlled. So you might have scar that is as less visible as a normal child with a thin line to a slightly wider one. So the idea is that there is less stretch, less scar. The nose is usually stretched towards the cleft side, so it's flattened out. So when the surgeons do the surgery, they bring it together and they bring the nose forwards and they give an architecture, a shape for the nose. When the tissues tend to tense up and they want to go back, and lack of bone at the back, because there is a lack of bone, I'll come to that in a minute. Lack of bone at the back means that the tissues, the nose goes a bit deformed, or we call it relapse, goes back to where it was before, not entirely to an extent, so the aesthetics is lost post-surgery. So the idea of the nasoalveolar molding, which is currently controversial because there is no clear evidence for it in the long term, is that you mold the lip using a plate. The lip and the palate is molded using a plate. Before the child goes for lip surgery at 6 months, the two sides, which a 15 millimeter gap, is close together to bring them almost towards each other, and makes it much easier for the surgeon to just suture it in lay terms, to tie it together. There is no stretch, because most of the work is done before the surgery with a small plate like you see the baby has got there to push it together. All sounds much nice and beautiful, because the baby is going to be given a plate, the segments come together, the surgeon suture it. It's not as simple as that for the baby themselves and for the caregivers, the parents and the extended family that care for the child. Why? It's because When we do a plate, these plates have to be adjusted every week. So imagine for the first 6 months, a baby is going to have a plate which is something like what you see on the picture in that screen, like this, with some straps and elastics, 24/7 on their cheeks, and the baby has to come to see the orthodontist once a week or once every fortnight. So wherever they are, whatever part of the world they are, they have to come to the orthodontist in clinic to visit them every week or every 2 weeks for the first 6 months. Imagine the burden that they have. For a patient or for a caregiver with low socioeconomic status, they have to leave their daily wages, come to the clinic, and then attend to the orthodontist, go back. If they're further off, it's just a day's wage that's gone. Apart from the burden at home and to care for the baby, there is also increased burden, financial burden for them by leaving their job, coming through the transport and etc. Tremendous efforts by the non-governmental organizations like Smile Train in India, who have actually made it possible because they fund the travel, they fund the surgery, they fund the medical care. Very, very appreciative efforts by these organizations. Both the fragments come together at the around 6-month mark, and then the surgery happens. Having said all of that, we can see a visible closure of the defect at 6 months. But what we don't know is if the child at 5 years is any different to a child who hasn't had this NAM treatment in 6 months. End of the day, we are not bothered about what happens at 6 months. What we're bothered about is what happens at 5, what happens at 10. How does the baby look at 18 years of age and the rest of the life is what we want. Does this 6 months of increased burden, both in terms of the burden of care, the burden of the family putting their time, and the burden of finance, the economic status, is it worth doing it for the first 6 months that at 5 years the baby has a slightly better result? The child has more aesthetic result than not doing this treatment. That evidence we don't have, and hence it makes it a controversial treatment option, with some centers using it, but a lot of centers not doing this treatment. Most of the babies go straight to surgery at 6 months of age. This is an example of a baby who went through this treatment. You see on the left, this baby has a 13 millimeter cleft, and that was around 15 days after birth. And on the right, the baby had no surgery done at 6 months, had a NAM plate, put everything together, and see how the aesthetics of the baby is. And that has changed from 0 to 6 months of age. It looks amazing. The parents are really pleased. Everyone's pleased. The surgeon is delighted because they don't have that complicated surgery to do. So the surgery becomes much less complicated. So they love it. The surgeons love it. But the real situation is, how is it going to be at 5 years after birth, which we don't know the answer yet. But anyway, let's keep going. We don't know if it really works and whether we should do it or should we not. We don't know how effective it is in the short term. Perhaps more evidence on it short term, but not much of evidence on the long term. Does it help feeding? I don't think we have clear evidence that it does not help in feeding. We talk about feeding plate. A lot of patients, a lot of clinicians talk about putting feeding plates for these babies. But what the evidence points out is there is absolutely no indication for feeding plate. The evidence is really clear. All they need to do is see a feeding nurse. Postural adjustments at the time of feeding is good enough to have a healthy feed, and the baby's growth is quite normal to the normal growth. So feeding plate, which was used 2 decades ago, is not used anymore. So again, the question, some clinicians argue that my NAM plate is going to be in my feeding plate. Having said that, that has no evidence, and feeding plate is not something that we recommend at this stage. Is it cost effective? Absolutely not. It does take a lot of time for the parent, for the caregiver, and for the clinician. It is quite stressful for the parents and the caregiver to bring them in terms of the treatment, but also to see those babies strapped up with plates and straps and gluing, and then spending the time to remove it and then putting it back in. Do we need it for every case? Of course not. The wider ones, possibly yes. The narrow ones, just leave it and they go for surgery. So there is no clear demarcation, but anything less than 5 millimeters of gap perhaps needs no NAM. They can go straight. But there is also some clinicians arguing that the nose gets better whether it's 5 or 15, and it's worthwhile doing NAM for nose alone, may not be for the alveolar segments. Well, there's no evidence for any of this. And how do I do it? It's a lot of work for the parents and the caregivers, so I bring them all in one of my clinic together. So one of those patients will be the one that has gone through the treatment. Some of them will be midway, some of them will be coming to start with the treatment. This routinely happens in my clinic, and they all interact. I put them all in one place, let them interact, and that's the best information you can give those ones who are embarking on this treatment. Whether they want it or they don't want it, it's up to their choice. We provide the options and they take it based on not just what the clinicians have given, but also their own patients and parents who have gone through this treatment and who have been with us for the first 6 months of their life. And then they come to us for further treatment. We get the consent, and then we get started with our treatment. Impressions, we have standard impression trays to take them. Got to be very careful taking an impression to a baby. There is a risk of choking, so make sure that you have enough experienced clinicians and medical professional in terms of in case of emergency. We have different sizes plate. We measure the plate, and the alginate impression is not taken because of the consistency. The only one that we are allowed to take, we do, is the putty impression, a silicone impression with a thick putty, no wash, just a putty impression. For a bilateral, we have a tray with a handle, which is something like this, which can help doing the impression. We used to do this. We used to put the baby upside down with parents or our own clinician holding them. We don't do them anymore. We just, right now, we put them on the side. We do the impression from the side, but we make sure that there is a patency on the nasal air passage while we are doing the impression. Once the impression is made, we give them a plate, which is something like this. The way the plate works is the plate is glued on to the right fragment. In this one, the patient has got a cleft on the left, so the right gum pads, the right alveolar segments, the plate is glued with a denture adhesive. When the denture adhesive glues the plate, the parent then puts a sticker to pull the plate from the right to the left. So when the plate is pulled with an elastic, the bigger segment, which is something like this, closes up and closes the gap. So this is how the thing is, the greater segment from when you look from the bottom up. This is how the cleft fragments look. The plate is glued onto the segment with a handle coming at the front. So we use the elastic to pull it down, and the plate moves from here to come down and touch against each other towards the end of treatment. So this is how the start one is on the left hand side, and on the right hand side of our screen you see the cleft fragments are opposed and they've brought together. So that looks much nicer from the photograph, on the photograph, and the patients are quite happy with the visible change that they get over the 6-month period. Once the alveolar segments are together, we start with the nose. We want to also make the nose look better. So that's how the nasal stent looks. So we push the nose into that direction to give them a much more pointy nose. You can see that there is a lot of work happening for the first 6 months, for which they have to come every week or every fortnight to get adjusted, to make sure that everything is going on track. Once it's all done, we also have some problems with it. We have problems of plate breaking out, plate not gluing in. These are all measures that can be sorted. A lot of patients also complain about cheek irritation because of the straps and the adhesives that we use. Again, we give them other advices like having some oil and giving them some free time and so on. But most of them go through the treatment, a rough start, but a really nice finish towards the end, and they become very, very attached to us. As the baby grows, they start to move they become quite mobile, and they start to move their hands, and they start to kick, and they start to pull off the plates. So it becomes quite a task for the parents to keep this going until 6 months of age. Redness in the cheeks, most common ones. Sometimes the fixer tastes bad, and patients and the child keeps crying because of the taste, but they do get used to it after a while. They are crying all the time. If they are crying all the time, that means there is some extension. You've got to make sure that the plate is not causing them any there's no sharp bits, it's not causing them any harm or pain inside. If it is not, usually they're okay. Number of visits, 15. mild cheek redness, and so on. So this is how the baby looks. Oops, sorry. This is how the baby looks. The one that you saw in the picture before, the cleft fragments were put together. This baby had a unilateral complete cleft lip and palate on the left, and a bilateral but incomplete cleft lip. There was a small incomplete cleft lip on the right hand side. This picture on the left is immediately post surgery. The middle one is pre-treatment, immediately post surgery, and the boy at 4 years of age. Quite exciting little boy. We love him when he comes to clinic. He keeps us entertained. Well, initially we used to entertain him, but the change is so dramatic that they start entertaining us, and it's good fun. And they all know that we'll be seeing them for the next 14 more years. 1 to 7 years, not much work for us as orthodontists. It's quite a time. We leave it to the speech pathologist, oral health people, that's dentist, and some audit records and joint clinics. They come and go, anything to pick up or just see, monitor, and then go. And we learn from doing these audits. We look at our own results at 5 years clinic. How well have we done? How poorly have we done? Has the NAM worked? Has the NAM not worked? How do the surgeons feel about the NAM? How do we feel about the surgeon's work? And how do we feel about the speech pathologist's work? So it's a brilliant clinic where we learn from ourselves on a daily basis. And then at the 7 years mark, the second lot of treatment starts. We bring them on the joint clinic, and this is how the joint clinic looks. The nutritionist on the left, the speech pathologist on the second one, the one behind is another speech pathologist, and we have our research orthodontist with the blue salwar, and our surgeon Altaf Hussain, the man behind the whole unit. He is an amazing surgeon, one of the most beautiful hands. And then myself sitting down and relaxing while the others are taking the lead. And Charanya is one of the MaxFac surgeon. Altaf is a plastic, and Charanya is a MaxFac surgeon. And then we have our cleft nurse and so on. The patient right in the middle. You can see how intimidating it is for the first time patient, but then they get used to it after a while. They know each and every one of us at the time point of 7 years, and it's more enjoyable and fun. We talk about that life and so on. It's a lengthy clinic. And we love to do those clinics and interact with our patients. So at this point in time, this is how they look. If it's a bilateral, so this is the boy who had a bilateral cleft lip and palate. You can hardly see the two central incisors. They're tucked back behind the lower arch. So he needs some work doing. Now I'm going to explain a little bit about what happens at primary at 1 year and what happens now. Again, in lay terms. So when the baby is born, the first surgery to be done is putting the lip together. So the lip comes together. When you look at them from the outside, the face looks beautiful because the lip is together. There is no sign of cleft from inside, although it is not operated. So at 1 year of age, we operate for the palate. When we say we operate for the palate, we bring the attached gingiva, the gums, the palatal mucosa together, and we seal them. So the two palatal mucosa are brought together and sealed. So what we effectively do is soft tissue closure of the lip, soft tissue closure of the palatal mucosa. What we haven't done is the bone. So the hard palate, which is not fused together, is not fused together at 1. We are only closing the palatal mucosa, and we also close the nasal mucosa. So there is 2 soft tissue lining at 1 year. The palatal lining and the nasal lining are closed with no bone in the middle. So this is the nasal bone that is lacking, palatal mucosa. So the communication between the oral cavity and the nasal cavity is blocked by these 2 soft tissue mucosa. But what we don't do is anything to do with the bone. So without the alveolar bone, your permanent teeth are not going to erupt. Your primary teeth won't erupt. Of course, that is fine. We don't mind too much about the primary teeth not being in place. But your permanent teeth are not going to erupt. So at the time of eruption of permanent teeth, which is around 10 years of age, we want to put some bone in so they can come through in that bone. They won't come through in a vacuum. They won't come through in dead space. They won't come through if the bone is not there. So if you don't do a bone filling there, your teeth are going to be impacted. So to make it normal, you put some bone in that area and then you allow the teeth to come through. We call this alveolar bone graft surgery. So we call it a graft, we put bone in. But where do we get the bone? Imagine there's a huge hole in there between the 2 soft tissue. You can't just get bone from somewhere within the oral cavity. You need a good chunk of bone. we take them from the hip, which is called a iliac bone crest. So you scoop some bone in the hip, right in the hip. You can do it at left or right side, the clinician's preference. You scoop a bone like an ice cream scoop. You scoop it, you take it and put it in the mucosa. So they open the palate like a book. So this is the buccal flap, this is the palatal mucosa. They open it like a book, put some bone in. The palatal mucosa is still intact. They don't open both sides. So they open one side, fill it up with lots of bone, chunks of bone, close it and suture it back. So the idea of doing this is because you're putting their own body bone. They're putting a bone from the hip, which is a similar bone to the palatal. So after 3 months, you see the bone merges with the rest of the palate. So at that point is when you get one maxilla. Until then, the maxilla is 2 halves. You put it, you have one maxilla, which is fully integrated. The bone, we call it osseointegration. Everything integrates to form one bone. The beauty of human body is that it becomes one bone. Now it's a normal baby, normal child with one bone, so teeth can come through on its own. This is highly technically challenging surgery. So if the surgery is not done well, the bone does not take it up and dissolves. It resorbs again. So if it is done really well with good packing and good seal, it's like a let's say like a plastic bag. You put water in it. The bone is like a water. You put water in it. If the bag is not sealed, if there is a hole, the bone is going to leak through. The water is going to leak through. So you have to have a book that is opened up and closed up with proper vacuum tight closure, so the bone end does not leak out. If they can do the job really well, then it's 100% success with alveolar bone graft surgery. Our unit, from the recent audit we did, we had a 96% success of alveolar bone graft, which is one of the best results. In most of the centers, we would expect a similar result because these are elective procedures. When you do it, you want to make sure it's perfect. And these surgeons do nothing else apart from just the bone graft surgery. So they're quite intense, but quite good in terms of looking at the outcomes. So they put the bone graft in terms of bilateral. There is 2 sides, so you put one side bone, wait for 6 months, and then the other side bone, so that you have one part maxilla. If it's unilateral, one bone, job done. Bilateral, 2 times at a 6-month interval. This is our protocol, but protocol might vary from different centers. So you have 2 photographs, 2 radiographs on this slide. The one on my left is the cleft without the bone. You can see a radiolucent, a thick line coming through. The one on my right is the one that you see with the bone in, full bone in, and you can see the difference between no bone and bone here. And this is taken 6 months after the surgery. So there is a complete union of the maxilla. And now you could actually see, if you watch it closely, the left-hand side picture has got a canine that is highly placed without any bone. Whereas the right-hand side picture, the canine is dropping down. As soon as you put the bone in, the canine wants to come in because it is waiting for something to come out, for some kind of bone to come out. As soon as you put the bone in, it's so happy, it just jumps out and it starts erupting naturally. So end of the day, a good surgery, a natural eruption of teeth, well-aligned arch, and less further future surgeries for the child. If it is not done and the surgery is not done, they have to redo it, or they have to expose the canine, bond a gold chain, and bring it down. All sorts of complications happen. Now, we've talked about surgery. Of course, it's not my cup of tea. I'm not a surgeon. I've given you a layperson's perspective. If you ask a surgeon, he might say, I'm mad, I'm giving all wrong information. But I hope I'm giving the right information. Now let's talk about orthodontics. What am I doing as orthodontist for these patients? What is my role? So in these cleft patients, the teeth are everywhere. Right? The surgeons find it very difficult to just open it as a book and put a bone in and come off. That's not that easy for the surgeon. They want access from all sides, from the down, from the sides, and from the root. So they want us as an orthodontist to make it a little more aligned and give them more space to put bone in. Point 1. Point 2 is, if you look at this picture here, right, there is the 2 incisors and there is the 2 other fragments tucked in. So you see there is a gap on both the sides. If I want to widen my arch, it's much easier now because there are 2 bones, you widen it, it'll just jump out. If I don't do it now, I put a bone graft in, the maxilla becomes one bone, and then when I want to widen it, strong bone, teeth are not going to move. My task becomes much more difficult if I'm going to widen it or make the arch aligned after the bone graft surgery. So that small window I have before the bone graft surgery, I'll put a brace to straighten the teeth, to align it so that my later treatment becomes less complicated, and I also give more access and more space for the surgeons to put more bone in. I'll show you some examples in a minute. So these are the time points. At 7 years, we are looking for eruption of centrals, we're looking for eruption of laterals if they are present. A lot of the time laterals are missing in these cleft patients, and then you have the orthodontic treatment as preparation. So let's look at this young lady, beautiful young lady who has got a unilateral complete cleft lip and palate on the left hand side. She's operated for lip, operated for palate, very nicely done operation. You see the palatal shelves, palatal surgery looks amazing. It looks like non-surgical or non-cleft palate case. But anyway, so the teeth are twisted. There is no space for the surgeon. You see how complicated it is on the bottom picture on the left hand side where it shows the left buccal segments. You see how complicated it is for the surgeons to open the buccal mucosa and put bone in. There is no access from the occlusal side. So the surgeons want orthodontists to widen it, make the tooth a little more aligned, correct the cross bite, and give them a better arch, which makes their life much easier. So they always depend on us. The surgeons, more often in cleft case, every surgery, prior to every surgery, they want us as orthodontists to make their life easier, to give them a better stage, to give them a much easier stage so that they can go and do the job much well. So why do we need ABG? I think we've talked more of it, but there is also other reasons why we do ABG. If you look at the face from outside, most of the cleft children have one side where there is normal, has a good nasal base. The other side, because of lack of bone, this side of the nose goes in. So if you put bone in, that comes forward and have a symmetrical looking nose on both the sides. For speech, the surgeons, the speech pathologists also want good bone to get a better speech. And then support for anterior teeth. So what do I do? There are different types of appliances. We'll go through them in a minute, but some appliances I do. I like my fixed appliances. So I use my fixed appliance to widen, to straighten, to correct them. The rough treatment time is around 6 months. I don't do it any more than 6 months because my burden for the patient that I'm going to give should be as less as possible. If there is anything more than 6 months, I start to get worried. I want to keep it within 6 months. So I put a fixed appliance, widen the arch, get them a little more straightened, and then give them a better looking smile. So at this point, if they are in high school, if they are in middle school, they are then going to high school. So when they go to high school, if at all they change the school, they have a much more aesthetic teeth, they have much more aesthetic face, so they go in as a different person. Their social life gets much better. So that's the whole idea of putting brace at this time point. That's also one of the idea of putting brace at that time point. So you see how well the arch is aligned. It's reasonably well aligned. There is a limit to how much we can achieve. We can't completely derotate them because there is lack of bone. If I upright and put them straighter, there's going to be no blood supply to that if it goes into the empty space. So I have to keep the apex within the bone and do as much as I can to make it more straighter. So that looks a lot more straighter than how it was at start. And the crossbite is corrected. The surgeons are now ready to put bone in. Now they can open it like a book and then put bone in. And that picture there shows how the teeth was before treatment. There are different types of appliances we use. They start off with this appliance, which is called an expansion, rapid maxillary expansion device. It's glued in. They open the screw once a day or twice a day to widen the two fragments, and it gets quite nicely widened. A similar one is called quad helix. I like to use quad helix because I can then work with my fixed appliance at the same time. So it's a quad helix appliance that we use, but sometimes these children have really narrow arch. So the photograph that you saw before, the photograph without the brace, I'm just going to nip into that photograph if you want to see it. The photograph that we got before is the same child with before treatment and after treatment. So you see that this is the one that you have after you have expanded. This is called a tri-helix, where there is limited space to put the appliance in. And in a bilateral case, this is what we expand. You see how it was. The two premolars are kissing each other. We widen it. We make them a lot more wider, make them much more bigger, and we give the surgeons a good palatal area to put bone in or to do whatever their palatal revision surgery is. from the front, this is how they come to us at the age of 7, 8, and then we give them fixed brace to straighten teeth. You see, this is a bilateral patient. You have the anterior maxilla coming entirely down, right? This is 250 times overbite in orthodontic terms. The anterior maxilla is completely pushed down. The posterior is quite high up. It's a lot of work for us to do, and that's how it looks on the occlusal image. So we give them a brace. This takes a little longer. I'd say up to 9 months of fixed appliance. I don't do much more. 9 months is my time point. So I'd want to make sure every visit is worthwhile for that patient. We see them every 4 weeks. And then we widen it. See how wide the arch looks now? The wider the arch, the two canines were touching each other. The arch looks wider. Now the anterior segment can be brought back and tied up. So in this case, you see that the picture here before the brace treatment, you see these two canines are touching each other. The two incisors cannot go back and fit themselves in. So as I widen the arch, so from here I widen it so the two fragments can come back and fit into that space. The space has to be exactly coinciding with that length of the premaxillary segment. You do too wide, it's going to be floating. You do too small, it's not going to go and tuck back. So the fragments, the sides have to be wide enough to come and get that anterior segment tucked in. So then you give it to the surgeons. If you pass them on to the surgeon, we take them to the joint clinic. The surgeons are delighted. I've given them perfectly what they want. They're delighted. His job is much easier. So they tend to get the anterior premaxillar tucked back and fit it in. And that is how he looks immediately post-surgery. You see the amazing result. He was showing the entire teeth, but now he's just showing the lip and a beautiful looking face. Patient is extremely delighted and the surgeon is delighted, but all we do is 9 months of hard work, putting the brace in the correct position, working with everything, giving the stage set for surgeons, and they don't see any improvement then. They see a small amount of improvement. And once the stage is set, the surgeon comes in the morning, the patient goes into theater, the surgery is done, they come back, and the whole family is delighted. They think the surgeons are the god. But they don't understand how much work we as orthodontists have done for them. Of course they do, but I'm just telling, that one day change the surgeons do. That's what the patient, that's what the family gets delighted about. But we love giving that stage for the surgeon, and it's an entire team effort that we work. Cleft is a team effort. It's not just one person's job. And I couldn't work, I couldn't live without my surgeon. The surgeon should take the credit, but I also help in the patient's journey. Now, so we've seen the mixed dentition. We're moving now on to comprehensive orthodontic treatment.